Hi everyone, my name is Vicky Sanderson. I'm a nurse practitioner practicing out of London, Ontario in family medicine. And I am here and very excited to talk to you about core diagnostic reasoning principles, which really is what being a clinician and a nurse practitioner is all about. So, what we'll be touching on today is Bayesian reasoning and systems of thinking. So, learning how we think through clinical cases. Rest assured, all of this content is on the NP Reasoning Education blog. So if you feel that these concepts are a lot to digest, that is totally normal. You can read all about them and take your time after the video. So, again, what we're going to be diving into is how to apply Bayesian reasoning and System 1, System 2 thinking in clinical practice, ultimately, learning what being an NP is all about. So, what is diagnostic reasoning? Bayesian reasoning is essentially when our brain constantly has to update a hypothesis as new evidence becomes available. So, we're constantly updating our beliefs as we go through that diagnostic process. And it's difficult. It can certainly make our brains hurt, especially when we're faced with very complex atypical cases. And truth be told, many people that we see in clinical practice are not textbook perfect cases. So, this is where diagnostic reasoning comes into play. It's synonymous to the scientific method that we learned in high school science. So, let's get into it with some clinical cases so I can illustrate what Bayesian reasoning is when we have that patient sitting in front of us. So, case one, let's say a person's coming in to see me with a skin lesion. So, I always start with a list of possibilities or a list of hypotheses, right? Could it be a malignant skin lesion like a melanoma or squamous cell or basal cell carcinoma? Or is it non malignant like a seborrheic keratosis, dermatofibroma, and a long list of other non malignant skin lesions? So, this is my initial hypothesis. To test these hypotheses, I need to perform a history, physical exam, and perhaps do more tests to update these hypotheses. So essentially, ruling things in and ruling things out as you test the hypotheses. So, with the history, the person's saying there's been growth, there's a change in color, it's darker, and they have a personal history of basal cell carcinoma. So, already I'm thinking, could it be more malignant skin lesion? With the physical exam, I see that it's fairly large, so 6 millimeters, it's raised, it has rolled out borders. So, right away, my hypothesis for skin cancer, I need to keep testing out that hypothesis because I am concerned with those findings. I go ahead and do a skin biopsy in clinic, and essentially, I can't confirm that it's a skin cancer with the history of physical exam alone, which is why I need to do that biopsy. And lo and behold, the biopsy comes back and it's in fact an inflamed seborrheic keratosis, which can mimic a basal cell carcinoma. So, with that new data point, I've updated that hypothesis. I know that I can be fairly rest assured that it's an inflamed seborrheic keratosis. Now, let's dive into a second case that it's a bit more atypical and a bit more complex. Person's coming in with a rash. Okay, I have a starting list of possibilities or hypotheses for a rash. It's a long list. So I like to break it up into these buckets. Could it be an infectious rash, a life threatening rash, an irritant rash, like an irritant dermatitis or an eczema picture? Or could it be an allergic rash, either chronic or acute? So, with the history, I learned that it's been 3 months of this rash. It's itchy. They've tried steroids, they've tried antihistamines, nothing's helping. It's mainly on the torso and the back. On the physical exam, I see that it's kind of a raised red, scaly, purplish, patchy rash, low on the waistline and on the back. So, I'm scratching my head. I can't figure out what this is. Could it be an allergic or irritant? Because it is itchy. It's less likely infectious with a 3 month history of a rash. It doesn't fit, physical exam doesn't really fit a Lyme, erythema migrans, etc. And life threatening, yeah, I got to think, is this, more of a cancerous type rash? They haven't taken any new medications, so it's less likely a medication reaction. So I go ahead and do that biopsy when in diagnostic doubt with a rash, because there is that diagnostic uncertainty. Biopsy results come back. It's an irritant dermatitis, which it doesn't really help update that hypothesis for me because it's not fitting the history and the physical exam. It's not fitting my patient's picture. And irritant dermatitis is really an umbrella term. It doesn't give me a diagnosis. So what do? I rebiopsy, which sometimes you have to do. I biopsy a larger area and in a different area of that rash. And lo and behold, that biopsy comes back with the cutaneous T cell lymphoma, which is a must not miss diagnosis. And that fits that clinical picture. This type of T cell lymphoma can present low on the waistline, the back, it's chronic, it's itchy, treatment isn't helping. And this is where it's a really good illustration that the diagnostic pathway is not linear. You constantly need to, update your hypotheses and integrate all this data that's coming through. And it's very difficult. And truly, it just takes a lot of time, practice, patience, and seeing hundreds and hundreds and hundreds of patients. So now let's get into thinking how our brain actually processes and thinks through problems. How do we approach problems? So it's, this widely adopted concept of flip-flopping and using system one and system two thinking. We'll use examples to get into that in a minute. So what system one thinking is essentially we're seeing a person in front of us. We're comfortable with that case. We've seen this presentation before. That's like that initial skin lesion we just worked through. I was able to use gut intuition, automatic processing. I'm thinking pretty quickly through that case to get to that answer quickly. This type of thinking, it is prone to bias or error because we might be missing some key diagnoses, but this is helpful because sometimes we have to think quickly through cases, right? We can't spend hours on each case that we see. It just wouldn't be practical. In contrast, system two thinking is maybe that rash presentation where we have to slow it down. I have to be more analytical and deliberate in my thinking process because I'm maybe less familiar with the case, or maybe the case is presenting more atypically and not textbook perfect. These are the cases we have to slow it down, take more time. And of course, it's not feasible to be, again, thinking through each case on hours on end. We'd never get through patients, right? So with this type of thinking, we use what we need individually in the moment, and it's based off of what we've seen, how familiar we are with presentations, how comfortable we are with presentations. We can in fact go back and forth between system one and system two thinking in a single case. And word of advice, right? With novice learners, we're more often going to be in that system two thinking where we have to think through things more slowly because novice learners have seen less. Whereas, perhaps a provider working in family medicine for 10 plus years, they're using system one thinking more often because they've seen so much, they can be quicker about how they think through cases. So let's use a couple more examples to illustrate these forms of thinking. So case one, we're looking at a patient presenting with a 3-day history of a sore throat. So it's an acute sore throat. Let's say, I've seen 15 of these cases in the last couple of weeks because it is flu season. Right away, I'm kind of jumping into system one thinking. I can be quick and use my gut intuition. Seems like a fairly straightforward presentation. With my differential buckets, I'm thinking about what mechanisms cause sore throat. So is it an infectious mechanism or a non-infectious mechanism? Examples, viral, bacterial, fungal, or could it be more reflux, irritant, or allergic? So on the history, I learned this person has a sore throat. There's no cough. They've had a fever. They feel just generally unwell. And in fact, on physical exam, we're finding some, swollen tonsils and exudates, some lymph node swelling in the neck. And, we go ahead and order that rapid strep test and it's positive for strep pharyngitis. So there's my diagnosis. I maybe spent 5 to 10 minutes with this person. I've used my system one quick gut intuition thinking because I'm familiar with this type of presentation. I'm confident with this diagnosis. In contrast, let's see another patient presents to you with a 4-week history of a sore throat. So right away, I need to stop, pause, and think through this case more thoroughly because it's atypical. I haven't seen a chronic sore throat in some time, and maybe I forget what I need to be thinking through. So with my differentials, I start with a list of hypotheses, Could it be an infectious or non-infectious cause? So with that, I'm adding, could this be an HIV, a chlamydia, gonococcal pharyngitis? Could it be a hematologic malignancy? So with the history, I'm learning that they do engage in high risk sexual activity. They feel generally unwell. They have pus-like exudates on their tonsil, and they do have swelling lymph nodes in their neck. I do a bunch of different tests. I send off throat swabs for chlamydia, gonorrhea, and labs for HIV, and throw in a CBC to rule out hematologic malignancy. So HIV, CBC come back negative, but there is a positive throat swab for gonorrhea. So this person does in fact have a gonococcal pharyngitis diagnosis. So again, with this presentation, I had to slow it down and think through all the possibilities because chronic sore throat, maybe I'm less familiar with and I haven't seen as much. So again, we use what we individually need in the moment based off our comfort levels, our experience, and that person sitting in front of us. So in summary, diagnostic reasoning is extremely complex, but we need to get into good habits early and use, constructive and efficient ways to think through cases. Again, we use system one and system two thinking interchangeably. So it's important to reflect on how we're thinking about cases, how we're thinking through cases to constantly, ensure that we're using appropriate systems of thinking. Thank you so much for having me. Again, all of this content is on the NP Reasoning blog, and I also have a free newsletter for primary care updates and other topics. And I'm excited to talk about the next topic soon.